So this abstract is looking at really a real-world analysis of thromboembolic event rates in patients with polycythemia vera in the United States. This is something that obviously when we're treating patients with polycythemia vera and essential thrombocythemia, one of the things we focus on is reducing the risk for thrombosis. However, I think when we think about what are the real event rates of this, I think that's somewhat nebulous, right? And we rely on some historical data to try to understand better what those rates are. And I think this is something we tried to look at using kind of these large real world databases that can perhaps capture this in a more modern sense. And so by doing that, we utilize this Optum market clarity database, which really pulls from over 105 million patients in the United States, and can give a better look as far as how often are patients with polycythemia vera experiencing thrombotic events before their diagnosis, after their diagnosis, and how does that differ based upon their risk status. And I think this can help us as we try to individualize care for patients with polycythemia vera moving forward, and especially as we kind of move into an era where maybe we're leveraging therapeutic agents either earlier in the disease process or really trying to make sure that we're choosing the right agent for the patient that comes into our clinic. When we did this, we as I mentioned, you kind of pull from over 105 million patients using this kind of market clarity database. But again, polycythemia vera is quite a rare disease, and so that's going to be quite a minority of these patients. But still, we were able to find over 20,000 patients with polycythemia vera that qualified for this study, with a median duration of over 4 years. I think this is certainly a substantial number of patients with polycythemia vera, and really gives us a better sense of how often these things are happening. And so when you look at those 20,000 patients, we found that about a quarter of those patients experienced at least one thromboembolic event during this kind of post-index period, so after their diagnosis. Most of these were defined as being strokes, some as myocardial infarction, so common arterial events. For venous events, the most common events were deep venous thromboses and pulmonary embolus. And then we kind of broke this down into risk. And so using our conventional risk modeling system, patients who have high risk disease are defined as being over the age of 60 or having a prior thromboembolic event. Patients who are low risk need to have neither, obviously be younger than age 60 or 60 or younger, and have never had a thromboembolic event. And so we kind of broke down these event rates based upon risk. And so we found that patients who are high risk due to the fact that they have a history of thromboembolic events, that's the highest risk for having another index event or a post-index event. And that happened in about half of patients who had a previous history of thromboembolic events. Patients who were high risk due to age, they had about a quarter of those patients had a thromboembolic event after their index period. And then patients with low risk still had an increased risk of thromboembolic events, but happening at only 13%. So really the risk status, so certainly high risk patients are high risk, but I think even those that have a prior thromboembolic event are the highest risk moving forward. I think that the implications of this are one, to get an understanding of what's the true risk of subsequent or just having a thromboembolic event in patients with polycythemia vera, and how does that break down by risk group? And I think what shows to me is that still the risk of having a thromboembolic event in the low risk patients is still pretty high risk. And so I think that this is a group that we need to think about how best can we mitigate that risk. Are there current therapeutic options that we have that can mitigate that risk, and what's the best way to go about doing this? But I think that this allows us to have some better understanding when we counsel patients of what their true risk is in kind of a more modern study. And once we understand that true risk, we can really start to capitalize and understand how to reduce that risk in patients across the board.